Thank you very much for inviting me to come and talk to you this morning. I am in fact talking on behalf of the boss, who apologises that she can't make this one. She's on annual leave at the moment, and so instead you get me, but thank you for that. I realise that I think I've let you down before now in terms of a speaker engagement due to a death in the family a few years ago, so I'm doubly glad to be here to kind of try and make up for that. So the address that I've been asked to give this morning is Infection Prevention and Control, the State of the Nation, and obviously that's quite a big topic for 20 minutes. So what I'll do is try and kind of give you one man's version or view of some of the key things that I think are on our minds and are challenging for the future. So I'll really begin with that future and say, look, I think it's pretty daunting if you look at the projections of where we might get to if we don't deal adequately with antimicrobial resistance on a global scale. It's fairly horrendous in terms of the number of deaths that we may have to cope with, the kind of costs around the globe that AMR may bring to us, and indeed the World Bank estimates that on top of these kind of gloomy predictions, if we don't deal with AMR, then about 28 million extra people may be forced into extreme poverty through the kind of shortfalls in economic output that may eventually result from being unable to treat infections. So this is a pretty dramatic problem. And closer to home, we already know that there are 33,000 deaths across Europe each year that are attributable to resistant bacterial infections. And if you put that together, that's the same kind of total burden of influenza, TB and HIV/AIDS put together. So it's really very considerable. Now, one of the challenges we face in the UK, of course, is bloodstream infections, and in particular resistant bloodstream infections. And one of the points I really want to make on this slide is that there is substantial regional variation across the country. The slide doesn't really show it, but obviously there are urban hotspots too, which probably reflect the concentration of tertiary care in these urban centres and the kind of complex care they deliver. But nevertheless, underpinning this, there is this substantial variation that hints at the fact that there's something we can do about it. Bloodstream infections have increased by 35% since 2013, and we are now coping with 53,000 resistant infections across 16 pathogen types each year. And about 60%, just over 60% of those are healthcare acquired, with just over 2,000 deaths per annum. So already we're really into quite difficult territory. And in terms of antibiotic use, we also have a very significant variation across the country, from high usage areas in the north and northwest through to kind of lower usage areas in the Midlands and the south. And I'm actually from Boston in Lincolnshire. I don't say that too often, but I am. And I'm very glad to see that Boston may be at the top of the list for some things, but it's in the cool zone for antibiotic use. So that's a good thing. Now, we shouldn't just kind of concentrate on the gloom. We should celebrate the fact that we've also had some real success stories. And if you look at Staphylococcus aureus as an organism which has given us real concern in terms of bloodstream infections, you can see that in terms of MRSA, since the early noughties, we have really driven down this problem through multiple interventions. The same can't be said of sensitive organisms, but nevertheless, I think as an epidemiologist, I look at that slide and I don't see a dramatic increase. And MRSA is one of our success stories, really. A 9.5% decline a year-on-year decline from 9.5% of resistant infections through to 6.6% in 2017-18. But still, in the black box, you can see that a very substantial proportion of those are healthcare acquired, and that's of concern. Now, in terms of Clostridium difficile, this audience particularly, will be aware of the couple of large outbreaks of ribotype 027 that have contributed to the picture we've seen over the last 20 years or so. But from a position in the mid-noughties of really having quite a dramatic problem, we have again driven this down, and I think it's another celebration story to be celebrated. But I would add that although the proportion of hospital-acquired C. diff has really been driven down, we still are beginning to recognise that there is a community-acquired problem related to C. diff, that I think we're at the beginning of a journey on understanding that and working out how to drive that down further. So, turning now to something that is very much going the wrong way. Gram-negative bloodstream infections dominated by E. coli, Klebsiella and Pseudomonas. You can see the red curve predicts, modelers have predicted from where we were in 2012-13 through to where, if we don't sort this out, we will end up in 2024-25. You can see the cyclical seasonal variation in infections, but nevertheless you can also see this gradual, maybe it's not so gradual, upturn in the number of infections that we may have to deal with. And if you can, certainly at the front, maybe at the back too, you can see the black line that's overlaid it. Those, of course, are real data up until the present time, and show, first of all, that the modelers are very good at predicting how this will run, and show the actual figures. So 41% of patients in England who have a bloodstream infection due to E. coli actually can't be treated with a first-line antibiotic, typically a penicillin, and that is of real concern to us. And E. coli alone accounts for 55% of all our gram-negative bloodstream infections. So a big problem that we need to think about how we're going to get on top of this. And in terms of the gram-negative infections generally, in relation to the total burden of antimicrobial resistant organisms, you can see that these organisms continue to dominate along with the gradual increase. And our interim ambition has been to see a 25% reduction in healthcare-acquired gram-negative BSIs by 2021 to 22, with a 50% reduction by 23-24. It's very stretching and it's very ambitious, but it's very important, and international commentators have said it's important that they kind of respect the fact that we are being ambitious about this. So that's our kind of close to home view, if you like. If you focus out a bit more globally, we see countries, 123 of them, reporting that they now have extensive MDR-TB problems. We also, at the kind of other end of the spectrum, see up to 2 billion people, particularly in the low and middle income countries, who can't adequately access antimicrobials. So whilst it is about driving it down, driving the usage down, there is this tension there about the fact that in other parts of the world, people die because they don't have access to antimicrobials, which I guess just kind of refocuses the burden on us to use what we have very carefully. About 700,000 people a year are dying from drug-resistant infections. If we keep going at the rate we are, there'll be a threefold increase in antibiotic consumption across the world by 2030. And you have to contrast that with the fact that we have no new antibiotic classes since the 1980s. You will have heard our Secretary of State make some announcements in Davos about a pilot scheme to try and de-link antibiotic prescribing, I should say antimicrobials, because we haven't settled on antibiotics yet, but I think it will be, but to de-link antibiotic usage from the kind of payment for purchasing the particular medicine, and to formulate a kind of subscription system that takes the pressure off manufacturers and gives them a bit more of an incentive to develop new classes of antibiotics for us. So, we just use too much of them. 1 in 3 patients in a UK hospital are on antibiotics at any one time, and 1 in 3 individuals takes at least 1 course of antibiotics each year. Our big uses antibiotics are the penicillins, the tetracyclines, the macrolides, and of course that largely reflects the way they are used in primary care and the kind of agents that get used in primary care. But having said all that, we have managed to drive down our use in humans, and we've driven that down consistently since 2014 by 7% overall. So I think we can be proud of those achievements in the last 5 years. And in that time we've pumped £360 million into R&D to try and deal with AMR. So we're a big international player, and long may that continue. And I was in the House of Commons last night at a welcome event, and various international speakers stood up and said that they really admired the kind of lead that the UK was taking in terms of the leadership position, but also in terms of the practical initiatives that we are trying to take to deal with this. So, it's a big kind of call out to you all, really, for the work that's going on. Now, you'll be very aware of the UK plan, the next 5-year AMR action plan, but for me, rather more importantly, is overarching it is the 20-year framework and the 20-year vision. This, I think, stops us from going from one plan to another, and possibly not retaining a kind of continuous vision across the period. And certainly in that vision, we're saying by 2040 we aspire to a world where we've contained, we've controlled, and we're effectively mitigating AMR. We don't say get rid of it, and I think that's very important, that we are being very realistic about this. And we see this very much as a One Health action across agriculture and the environment as well. And we certainly see that whilst the UK can show some global leadership, if there isn't that kind of political pull-through in other countries, this battle won't be won by the UK alone. So the kind of pillars in the plan are things that you would expect to be in there. We want to try and deal with the burden of infection by better treatment. We want to optimise the use of antimicrobials that we do have. And an important theme that continues from the last 5-year plan is that we want to see the implementation of new diagnostics, which I don't think has happened as rapidly or as completely as we'd wish it to have done at the moment. New therapies, I've talked about the pilot incentive scheme for antibiotics and the purchasing arrangements, but also vaccines. And yesterday's meeting in the House of Commons was focused on the use of vaccines to control AMR, both in terms of the vaccines we already have, such as pneumococcal vaccine, but also thinking to the future that we are entering a realm where it's more likely than not that we will see some vaccines coming forwards that will have a very big role to play, both in dealing with AMR, but also in dealing with healthcare-acquired infections. And I think that is a space to watch, and one where we will have to begin to have some new thoughts about how we possibly reimburse such vaccines in the future. They are going to change the landscape. But at the moment, I'll be honest with you, I don't think the vaccine and the AMR communities are talking to each other sufficiently. They are beginning to talk to each other, there's no question about that, but I'd like to see a bit more of it. So in terms of infections, our kind of, big 5-year ambition is that we can reduce a specified set of drug-resistant infections in the UK by 10% by 2025, and that we can halve the number of healthcare-associated gram-negative bloodstream infections. I've really given you most of the stats that are on this slide already, but that's the kind of big ambition we have for infection prevention, or infection reduction, I should say. You'll also be aware of the NHS long-term plan. In that, there is an ambition to continue to optimise use of and reduce the need for unintentional exposure to antibiotics in the healthcare system, to introduce access to appropriate tools around diagnostics, e-prescribing, which I think has an important role to play, and also to support a kind of system-wide stewardship of antimicrobial prescribing and surveillance and infection prevention and control. So it's very much at the heart of where we want to be in terms of how the NHS will move forwards. So I'll just finish now on some infection prevention highlights, or things that I see that will be important as we move forwards. First of all, continuing to improve surveillance. We are already the envy of pretty much all of Europe in terms of what we do on surveillance, particularly the things like the fingertip system, which bring granular data down to the level of individual prescribers. We'd like to see CPE made a notifiable disease. We'd like to see board-level leadership around I.P.C and AMR roles in all regulated providers. And we want to build capacity in the system to deal with infections. We'd like all consultations for infection to have a diagnostic code reported. We'd like patient-level data in real time to begin to appear in the system. And we want to not disregard the built environment in terms of changes to health service infrastructure and new build, so that we can kind of support, a kind of world-class infection prevention system driven by engineering controls as well as by what we do inside buildings. We're going to continue to push science, and we are really going to use our UK aid programme to knock on the door of other countries in terms of energising them to take their measures to reduce the burden of infections around the world. And finally, in terms of food, it's a bit of an understood area, a bit of a poorly understood area in terms of quite what the role of food is in relation to AMR, and that's work that needs taking forwards in the future. So there are lots of resources out there for you to use. I'm sure you're familiar with almost all of these on the slide. And I'm going to end up by saying we very much from the Department of Health and Social Care perspective recognise that infection prevention and AMR are linked agendas that are linked across multiple stakeholders, where really everybody has a role to play, and an international fight on our hands. Thank you very much.